So I have no conflicts of interest. So illustrating PAD. So your endo plan failed. What else? A lot of people say more endo. Well, let's say that fails too or not possible. Do we do open surgery anymore? Do a lot of vascular surgeons do open surgery anymore? We do here, and I think a lot still do actually. So let's kind of discuss our options at this point. Bypass is the historical gold standard for PAD. Autologous vein conduit is an option. Prosthetic conduit, or also cadaveric vein. Here's a nice schematic of looking at a vein versus a prosthetic bypass. Autologous vein options include greater saphenous vein, ipsilateral, contralateral. You have lesser saphenous vein. You also have arm vein as well. And here's kind of a quick example of your greater saphenous vein or your small saphenous vein options and where you would get them from. Small saphenous is a little trickier because you have to flip people oftentimes to get to it, though sometimes you can get to it by frog legging them. Arm veins, most common veins used are usually the cephalic with basilic vein. Sometimes it's a single segment and sometimes it's spliced. Sometimes it's a single loop. Veins, obviously, using autologous vein, there is a wound morbidity associated with it. You have options of reversing or not reversing it depending on your orientation. In general, it's thought to have superior long-term patency, especially below the knee. Prosthetic is generally used when vein is not available. PTFE is the most common one used. In the later years, we've had heparin bonded PTFE. We'll go through that more in a second. And also historically, people use Dacron bypasses more for inguinal, but less so now, more for aortoiliac occlusive disease. There's also cryo vein. Historically, it has lower patency. It's good for when there's active infection present, and we're in vision for infected grafts as well. So ipsilateral greater saphenous vein is considered the gold standard, and the best CLA trial may or may not confirm for us whether that's the case. When looking at GSV, this prospective trial PREVENT-3 that used 80% of veins with GSV in CLTI patients. In the ipsilateral GSV option showed that 1 year primary patency was 65%, primary assisted patency was 81%, secondary patency was 84%, and limb salvage was up to 92% in this randomized prospective trial. And the trial itself just looked at treatment of the vein itself, which showed no difference in outcomes. But these are the data looking at the greater saphenous veins in the trial. What about arm vein and splice vein? It's easy. It's an easy answer if you have a good greater saphenous vein. What happens if you don't? Do you try endo again? Well, we already said that failed. So let's move on. Let's get a little more difficult things. There's arm vein, there's splice vein, there's small saphenous vein. So what's the data out there on it? Here's an example of a case where we put two spliced veins together. So a lot of the data is older data because there aren't many large series of this anymore because people are so aggressive endovascularly. This is a series from the New England Deaconess Hospital in the now known as Beth Israel Deaconess Medical Center from the mid-90s. They looked at 250 arm vein grafts, which I don't know where you even find a contemporary series of that nowadays. 20% of these were composite vein. Majority, about half of these use cephalic vein alone, about a third use cephalic and basilic together, and the rest were basilic only. Contralateral GSV, this is important, was usable in over 38% of patients. However, they chose not to use this and go to the arm instead of using the contralateral greater saphenous vein to avoid making wounds into the leg, potentially to use it if needed in the future. Their limb salvage rate was a great 88.2% in the CLTA population here. And of note, almost a quarter of patients who had available contralateral vein end up using this for that other leg during the follow-up period. So I think it's really important to assess the disease in the other leg when deciding what veins to use. If the other leg is fine, you may be more likely to take the other greater saphenous vein. If the other leg is not fine, you may need the vein or don't want to make wounds, then you should consider an alternate autologous vein source. Another series from Beth Israel Deaconess from 2000 looked at later on at 520 lower extremity bypasses with arm vein. Patency at 1 year was 80%, 3 years was 68.9%, and 5 years was 54%. So these numbers are very good. Remember, the greater saphenous vein numbers were in the low 70s before for the prospective data. And patency rate was equal in composite versus single segment vein grafts. Another paper by looked at intra-inguinal reconstructions with arm veins, small saphenous, and remnant GSV. Third were composite veins. So comparing single segment versus composite veins, this showed a different outcome where the single segment veins had better patency at 1 year, 3 years, and 5 years. But there's still is still a 78% patency at 1 year though for single segment non-GSV, alternate sources of vein. So these numbers are very good. Again, this is an older series, which a lot more experienced groups. So that may not reflect modern outcomes, but these are possible to obtain. What about prosthetic? Prosthetic has changed over time, actually, and we'll go through that a little bit. Prosthetic are different types. There's polytetrafluoroethylene is the most common one, sometimes heparin bonded, sometimes not. And also there are different types. Some come with a cuff already made, as you see in the upper right. And sometimes you can do it with a vein patch, as you see in the lower right here. This is thought to potentially improve outcomes, especially in smaller vessels that you're sewing to. Looking at a meta-analysis of PTFE bypasses to infrapopliteal arteries. This is a non-propatent, non-heparin bonded from 2003. 5-year pooled estimates. Only 30% primary graft patency at 5 years and almost 40% secondary graft patency at 5 years. You still have almost a 60% limb salvage though. When looking at arm vein conduit versus prosthetic graft, one series looked at 290 bypasses for CLTI, 130 arm vein and 160 prosthetic grafts. These are non-heparin bonded grafts. Majority of arm vein had tissue loss. The majority of the prosthetic group had rest pain. And primary patency overall in this series, though, at 3 years, actually poor for both groups, but especially the PTFE group, a primary patency of 28% versus not even 10% for the prosthetic grafts. And you can see it does get better as it goes further down. And another analysis of looking at arm vein and lesser saphenous vein, as they called it here, also known as small saphenous vein versus PTFE grafts. It's a single center. They had preferred to use autologous conduit when possible, and autologous conduits were used more often to pedal arteries and less frequently treated with lifelong Coumadin afterwards. They saw similar patency and limb salvage, unlike the other group, but associate, not surprisingly, longer OR times with non-GSV alternative autologous conduit. And however, what about propatant? So propatant is heparin bonded PTFE. So the theory is that it's less likely to occlude, it's less likely to clot, and may have better patency. And overall, the numbers are better. So this was multi-center study looking at the outcomes for propatant. Above knee bypass graft patency was 82.7% at 1 year, much better than what we saw at 10% 3 years before, or at least on the trend. BK popliteal, 74%, tibial perineum, almost 80% at 1 year. These numbers are very good compared to what's else been published before then. And looking at secondary patency too, it's even more impressive. Single center looked at propatant grafts with distal anastomotic patch. There are different ways to do patches. There's Linton patch, there's a Miller cuff. There are many different other configurations for this. Some I've done, some I haven't done. This showed primary patency rate at up to 4 years of 85% at 1 year, 71% at 2 years, 64% at 3 years, and 57% at 4 years. So overall, good numbers. And these are in tibial artery bypasses using a cuff. And good secondary patency rates that you see here as well, and 84% limb salvage rates. And in their series, these outcomes were similar to their use of greater saphenous vein. Using the vascular study group New England, this is a consortium of about 50 hospitals in New England that started in 2003, and pulling the data, looking at different conduit types. So, and I have to be involved in this paper as well. So you look at single segment greater saphenous vein, alternative autologous conduit, and also non-autologous conduit. So alternative autologous is everything except for single segment greater saphenous vein, and non-autologous conduit includes prosthetic and cadaveric vein. So 50% of these were to infrapalpatile targets in over 2,000 patients. For below-knee palpatile bypass, there's no difference in any of these three types at 1 year: major adverse limb events, major adverse limb event-free survival, or primary patency. However, for infrapalpatile bypasses, non-autogenous conduit, again, that's the PTFE, and the cryovein was associated with higher major adverse limb events. This includes major interventions, amputation, and death. It was associated with a trend for higher primary patency loss and also a lower male-free survival. So who do you want to avoid prosthetic in? Well, people get worried about getting infections on. That's the biggest thing. So, the patient upper left might be great for a BK pop bypass, but may not be so good for a dorsalis pedis bypass with a vein patch. That's almost surely get infected. So you worry about people. It depends on where your target is, depends where your infection is, depends how bad your infection is. We published a paper when I was at Beth Israel Deaconess back in 2014, looking at 421 prosthetic grafts involving the common femoral artery. And here we had good follow-up for, on average, 4 years. And we saw that freedom from graft infection was about 89%. So 11% over time of these grafts somehow got infected. Factors that were independently associated with were redo cases, an active infection at the time of the bypass, female sex, and diabetes as well. And freedom from amputation, of these patients, almost 30% end up with an amputation, usually early on in the first year. And yet you can see people with graft infection are 10 times higher to end up with amputation than without. What about cryovein and what's cryopreserved vein? We haven't really talked about that too much yet. This is ideal in patients with active infected fields, people without conduits, potentially older patients who may not tolerate vein harvest, especially tibial vessels. A series of 81 cryoveins from the University of Florida showed primary patency at 1 year of 27%. So almost 3/4 were occluded at 1 year. And at 3 years, only 17%. However, their freedom from major amputation was 57%. So you have to think these people probably were last-ditch efforts to limb salvage. So if the vein lasts long enough that you can keep it open to heal the wound long enough, then great. But if you're looking for more long-term durability, this is probably not a great option for you. And note in this series too, anticoagulation was shown to be protective to the cryoveins from clotting off. So in conclusion, use GSV when available. Historically, splice vein bypasses have better patency. More contemporary data shows more variability, however, and some centers show no difference between splice and non-splice data. There's limited quality data for comparisons. Propatin shows better outcomes than historical non-heparin bonded PTFE. Also, we were comparing different eras as well, where you may do arm vein bypass a week back in 1995, but you may not do maybe 2 a year now in 2021. Also be mindful of infectious considerations and areas concerning for coverage, and give a good overall assessment of patient frailty. Thank you.